Dear colleagues and friends, thank you for inviting me and for listening to the value of subtotal petrosectomy with or without hearing rehabilitation. I have no financial or commercial interest to disclose. In 1919, Sir Charles Ballance published in his book on surgery of the temporal bone that the middle ear space is potentially a dangerous area towards the subarachnoid space. And when Professor Hugo Fisch visited in the 60s the house ear clinic, he observed during acoustic neuroma surgery that CSF leaks may lead to meningitis and even severe complications of that surgery. Therefore, in 1967, Hugo Fisch introduced the concept of subtotal petrosectomy, and this is published in his famous book on microsurgery of the skull base. Now, how does subtotal petrosectomy fit into conventional middle ear surgery? The concept is a complete exenteration of all pneumatic cell tracts of the temporal bone with or without removal of the attic capsula. Now, if I say all, and all is in brackets, you see on these pictures that the apical cells are not exenterated, only in case of labyrinthectomy or cochlear removal. So it's almost all the cells if you leave the inner ear intact. Now, subtotal petrosectomy is not much more than an open cavity, so it should be a part of the instrumentarium and armamentarium of a middle ear surgeon. In an open cavity, we remove all the cells which are here highlighted in green. And in a subtotal petrosectomy, in addition, we remove all the pneumatic cells of the middle ear space. If you look at the CT scan on the lower left, that's a post-op CT scan of an open cavity. On the lower right is the subtotal petrosectomy. So there's no much difference to a properly performed open cavity. There are a couple of concepts which are important to understand. In subtotal petrosectomies, we isolate the middle ear and mastoid space from the outside. Now, there are only two ways to get outside. It's the external ear canal, which needs to be properly closed. And closure means two layers, skin and periosteal layers. There have been publications that one layer is enough. And then if you read the publication, they see the complications. So you have to rely on a double layer closure. And we obliterate the eustachian tube. Therefore, no ascending infection is possible from the nasopharynx towards the middle ear cavity. Second, since we have closed external ear canal, we have to carefully remove the external ear canal skin as well as the tympanic membrane. And in order not to leave back any skin, it's a meticulous dissection. Otherwise, we would induce or leave cholesteatoma back. The tympanic membrane is removed together with the malleus and the incus, and oftentimes the chorda also needs to be resected. There is rarely the instance that you can preserve the integrity and the function of the chorda. Regarding the middle ear ossicles, we prefer to keep the mobile stapes intact. In some cases, the suprastructure is already missing or has to be removed. Third comes a thorough drilling, and as temporal bone surgeons, we love to drill, so we are the drill guys. The thorough drilling of all these cells, and I won't mention them all to you, you know them from open cavity surgery, but this is meticulous drilling to remove these pneumatized cell tracts, as well as the mucosa and the disease involved in these cell tracts. And at the end, the cavity needs to be obliterated, and the best material is abdominal fat, either through a periumbilical incision or in the lower abdomen, like for a hernia repair in the old days. So abdominal fat, and in addition, a second layer, the temporalis muscle and or occipital muscle flap. But recently, we have introduced the concept of keeping the temporalis muscle in place and just using the temporalis fascia as a flap covering the fat. And I will highlight this shortly. In Professor Fisch's book, and also in our publication already in 1998, we used in the beginning the S-type incision. This is mainly true also in lateral skull base surgery, so infratemporal fossa type A or B, which rely, or C, which rely on the subtotal Petrisectomy. So the S-type incision allows the proper exposure, and in the beginning we perform a large periosteal flap for the double layer closure of the external ear canal, and we have nice access to the temporalis muscle, which can be brought inferiorly over the fat and over the cavity. The disadvantage of this technique is that you lose bulk of the temporalis muscle in the temporal region, and therefore bold men or women, you see the indentation of the missing muscle, which really doesn't look nice. Secondly, if you plan to combine the subtotal Petrisectomy with an hearing implant, usually the implant is exactly where the muscle is missing. There was a recent publication, I guess it was from South Korea, and their complication was implants moving over time. Why? Because the implant was not properly covered by the muscle flap. This is why we have switched a few years ago and now preferentially use the L-type incision. It's an L-type retroauricular approach, exactly the same that we use for all our cochlear implant patients. We also perform a large periosteal flap, as you see it on the upper right, but then the periosteum and the temporalis muscle are raised superiorly, providing access for the drilling. And at the end, we bring back this flap. The periosteal flap is missing, and this hole is now covered just peritemporalis muscle. In the beginning, we used the free fascia, but nowadays we just make a U-shaped incision of the temporalis fascia and rotate the fascia inferiorly. So we flip it over inferiorly to cover the fat. And this is a very nice technique. You do not need the temporalis muscle. You can keep the implant safely underneath the muscle bulk. And this is our preferred choice, mainly in primary surgeries. Within the last about 15 years, I just checked this yesterday, we have performed in Lucerne 180 subtotal Petrosectomies. As in the beginning, we always use the S-type approach. There are nowadays 110 patients with an S-type approach. Currently, we only use this in revision surgeries where there's no temporalis fascia left. But in primary surgeries, we nowadays favor the L-type approach for subtotal Petrosectomies. Now, what are the indications to perform these surgeries? Number one indication are chronically draining ears with a severe hearing loss or even total deafness. This can be due to recurrent cholesteatomas. They're usually patients who had multiple surgeries before, usually always elsewhere, of course. But these are patients who do not fit the criteria for any hearing rehabilitation. The second group, but a much smaller one because it's rare, are the supralabyrinthine or infralabyrinthine cholesteatomas, which go, as you see in the lower right corner, the CT scan. Here is the cholesteatoma extending beyond the cochlea, and the axis is therefore a subtotal Petrosectomy with removal of the cochlea to completely remove these cholesteatomas. In brackets, they usually present as slowly progressive facial palsies. Then many patients who have chronic middle ear disease and multiple surgeries, and again, severe hearing loss with no option for reconstruction. This is an ideal group for the subtotal Petrosectomy as a final solution to these patients, or rarely osteoradial necrosis of the temporal bones. These are usually patients years or decades after irradiation of nasopharyngeal carcinomas who may present with a chronically draining and dead ear. Another indication, and now I'm coming back to Sir Charles Ballance, who stated that the middle ear space is a potentially dangerous space to the arachnoid, infection and meningitis. So if you reverse the sentence, if you have CSF leaks, like in transverse temporal bone fractures, which is a fracture through the otic capsula, in the middle CT scan, you see the fracture line through the otic capsula. This will never heal, so the space will remain open between the middle ear and the subarachnoid space. These patients are at lifetime risk of meningitis. If they present with facial paralysis, in 50%, the facial nerve is also cut by the fracture line. The best approach is the subtotal petrosectomy, facial nerve decompression or grafting, but the subtotal petrosectomy avoids late meningitis. We have rare cases of multiple neurosurgical approaches for all sorts of tumors who still leak to the mastoid or middle ear. The rare indications are arachnoid cysts, who usually follow the facial nerve over the geniculate ganglion, and it's difficult to close these leaks because otherwise you would compress the facial nerve. Or this is now very rare in Switzerland, to have multiple gunshot injuries to the temporal bones where you do not have the option of proper reconstruction and CSF leaks. Now, there are patients, as I discussed before, who present with severe sensorineural hearing loss, but there are many other patients who have a complete conductive block because of missing ossicles, because of the chronicity of the middle ear disease, but the inner ear function is preserved. So what are the options for these two types of patients? Again, in our 180 subtotal petrosectomy, we did not reconstruct anything in about 107 patients. In 14 patients, you can easily implant a BAHA, irrespective of the hearing loss. So if it's ipsilateral, if inner ear function is preserved, or contralateral, if the inner ear is lost. If you do a BAHA implantation, I prefer to do it in two stages. You do the subtotal petrosectomy first and you implant just the screw. You come back a few weeks later, and in the second surgery, you just puncture the skin over the implanted screw, and then you can place the abutment. Why? You don't want an open skin in a subtotal petrosectomy with underlying fat, which has not healed yet, which is not yet vascularized. Therefore, I always do the BAHA in two stages. I also never put a drain into a subtotal petrosectomy cavity, of course, not when there is CSF leak, but also to avoid any infection to the fat underneath. In 25 cases, we combined the subtotal petrosectomy with a vibrant sound bridge, an active middle ear implant, and in the majority of cases, in our series 34 cases, it was a combination with a cochlear implant. Now, if you go to cochlear implant surgeries, our preferred choice in all patients with chronic middle ear disease who require a cochlear implant is the subtotal petrosectomy. I would never dare, in doing an open cavity and placing an implant underneath cartilage layers and reconstructed middle ears. No, you do a subtotal petrosectomy, you have a clean ear, and you can implant safely your cochlear implant. So chronic infection is a main indication for subtotal petrosectomy and cochlear implants. Now, there is a discussion, a ongoing discussion, whether you should stage it. So first, the subtotal petrosectomy, like with the BAHA, and second, the implantation of a cochlear implant. Now, in all our surgeries, we did it primarily, and luckily, we did not have any infection of an implant. But I understand that some surgeons are more reluctant and prefer to do the surgery first, come back 6 months later, remove the fat, and then place the cochlear implant. Again, in Lucerne, we prefer to do it in one stage primarily. A second indication is malformations of the temporal bone, and I will briefly highlight on that. We already discussed the transverse temporal bone fractures, and in rare cases of obliterated cochleas, if you want to do a proper drill out close to the internal carotid artery, a subtotal petrosectomy would be the preferred choice in my hands, but the results of drill outs and cochlear implantations are usually not very exciting. Now, if you can remember this one picture, you have got the message of my presentation. This was a patient who was implanted elsewhere with a cochlear implant following tuberculosis, bilateral tuberculosis, and the surgeon, a very experienced cochlear implant surgeon, described difficulties at surgery, that he had no good view over the cochlea, and he needed to do a drill out through the posterior tympanotomy. Now, looking at the CT scan now postoperatively, we see his difficulties because there's no air in the middle ear space at all, and there was no drill out. He was just drilling in the hypotympanum and luckily did not hit the internal carotid artery, but he was below the cochlea because he made the wrong choice of surgery. He should have done a subtotal petrosectomy, and this is the picture at revision surgery. I highlight here the external ear canal would still be closed in a properly performed posterior tympanotomy, but there's no view. There's nothing to be seen. But if you do a proper subtotal petrosectomy, this is the same patient. We removed the old implant, and you see a nice view over the cochlea, a nice view over all the structures, and you can safely implant the cochlear implant. This is the intraoperative view and then the postoperative view of a properly placed cochlear implant in these cases of chronic middle ear disease, no view, and the only choice is a subtotal petrosectomy. Now, in temporal bone malformations, in like this malformations, there's only one way how to get to the cochlea. It's kind of a canalplasty. But here, the subtotal petrosectomy is a canalplasty with removal of the eardrum and the ossicles. And in these or similar situations with very narrow mastoids, protruding sigmoid sinuses, or other malformations of the temporal bone, the subtotal petrosectomy is the best choice. This is an old patient which I've operated about 20 years ago. At that time, we still did cochleostomies. Of course, nowadays, you can go through the round window easily. A big topic are inner ear malformations. And I come back to Sir Charles balance. If you have a CSF leak, there is the potential risk of meningitis. These children born with an inner ear malformation, and we know that they are an increased risk of CSF leak at the time of opening of the cochlea, either through the round window or through the cochleostomy. They are at risk of CSF leak, and Charles Balance correctly stated they are at risk of a lifetime risk of meningitis. So I never understood the concept that you would implant special electrodes with some silicone sheeting at the end of the electrode, which should avoid the CSF to pour out, or you pack the middle ear with some fascia and cartilage around the electrodes, hoping that the electrodes stay there and there's no CSF gushel later on. These are children, 1 year old, which may have 80 years down the line to live, and they're 80 years of risk of meningitis if they get a middle ear infection. Therefore, in all inner ear malformations with the risk of meningitis, we start with the L-type incision. We prepare for the closure of the ear canal. If there's no CSF leak, we can do a normal cochlear implantation. If there is a CSF leak, we always do a subtotal petrosectomy and a proper implantation in these cases of inner ear malformation with CSF leaks. Now, if you have preserved inner ear function, of course, you would not plan a cochlear implant. You may do a Baha implantation, but our preferred choice in these situations with properly regained inner ear function is the subtotal Petrosectomy with vibroplasty, an active miliary implant either on the mobile stapes or directly onto the round window. Now here, a round window placement is easy because you have all the anatomy in front of you. So round window placement is perfect in cases of subtotal Petrosectomies. We have looked at our 25 patients. So far, we had 2 cases of displacements, not from the stapes, but from the round window. And of course, then you lose sound quality and you lose hearing. You have to revise these patients. But in all 23 other patients, this was long-term stability. And we prefer to go on the stapes, but if the superstructure is missing, then you may go directly onto the round window. We've published also our first cases radiologically and audiologically. Now, what is the follow-up of subtotal Petrosectomies? 1 year after surgery, we always perform a CT scan. The CT scan allows us, it's like the handwriting of the surgeon. It allows us the correct identification of what surgery was performed. But in addition, I always check if there is air in the eustachian tube and middle ear. This would say there's no proper closure of the eustachian tube. Now, we would not go back and revise it, but it's just to check there's no air in the middle ear, so there's no risk of any ascending infections. In cases of previous cholesteatomas, we perform MRI to exclude residual cholesteatomas. There's no recurrence, residual cholesteatomas in the subtotal Petrosectomies. With the newer generation of implants, active implants or cochlear implants, MRI is possible. But of course, it is very difficult to see the shadow area around the magnets. Therefore, it may be more difficult to verify cholesteatoma persistence in cases of combined implant placements. Now, in our series, I come to the complications. We had intraoperatively 1 transient facial palsy, which recovered completely. We had 2 abscesses of the fat, which we just drained with a skin incision and let the pus come out, antibiotics, and we did not revise these patients. We had 1 hematoma or seroma. The main complication I usually tell to my residents is where they harvest the fat. So the hematoma were periumbilical, where you harvest the fat. So take care that you have a proper resident taking out the fat for you. We had 1 case, this was 15 years ago, with a pulmonary embolism, but luckily he survived and he's fine now. Long term, we had 3 residual cholesteatomas. 1 I removed after 3 years of watchful waiting. The 2 other ones are still very small, easily to be seen on the MR. They're not growing at the moment, so we just watch and wait. But of course, I didn't feel happy about these 3 cases of residual cholesteatomas. And we had 1 patient, was the case I operated recently. We had 1 case of a skin necrosis over the implanted magnet because he was wearing a strong implant at the speech processor, but we could revise, this was an active miliary implant, we revised this patient just with a local skin flap. We kept the implant in place, and luckily it healed. That's now 3 or 4 years later, and the patient is wearing a less strong magnet on his speech processor. So to summarize, the subtotal Petrosectomy offers maximum exposure over the temporal bone. It prevents ascending infection. Charles Bellens, remember his statement. It prevents CSF leaks and therefore meningitis. It is a beautiful surgery because you see all the anatomy of the temporal bone. And nowadays, with all these implants, it allows hearing rehabilitation using implantable devices. If you want to see videos on subtotal Petrosectomies with or without implants, you may Google Lucerne, Otology, and skull-base surgery, and you'll find our YouTube channel. We'll see there many videos which you can look at before you plan your own surgeries. But at the end, I'd like to thank my mentor, and the inventor of the subtotal petrosectomy, Professor Ugo Fisch, who died in the end of 2019. We still provide his courses at www.fimf.ch. In July in Zurich, the microsurgery of the skull base courses, as well as the otology courses. So thank you for watching and enjoy your next case. Good indication for a subtotal petrosectomy. Thank you.